Good morning, everybody. Good morning. Welcome to the Embark 5 oral presentations for 2019. Welcome back to our M2 students. STEP is now over, so I hope you're feeling a little bit more relaxed than you were a few weeks ago. I would like to start with asking our Associate Dean for Research, Dr. Richard Kennedy, to make a few opening remarks. Please welcome Dr. Kennedy.
Good morning, everyone. Am I on? Now I'm on. Good morning, everyone. I'm going to be very brief because, well, for two reasons. Number one, I had a very wise father, and I don't remember much of what he taught me, but he did tell me that it's important to stop talking before people stop listening. So I'm going to try to get that done. The other reason is, for some reason, all the drugs I've pumped into my body are still not dealing with the allergy season, so you have about 2 minutes before I start coughing. But I do want to begin by congratulating all the presenters today, and actually all the mentors, although some of them aren't here. We usually chain them to their desks or to their clinics on Monday morning, so I realize they're not here. And actually to all the students who've started through the Embark curriculum. It's a very unique program. It teaches a lot about research, but it teaches a lot about other professional skills that you take with you for the rest of your career. My son once told me, who's an ER doc, that he basically hated me as a basic scientist for 2 years of his life because I taught him at University of Arkansas. But later on, he realized that some of the things I told him he was still using. That's actually pretty scary. Just a little bit about what I hope for everyone in this room. Obviously, someday you're going to graduate from this place. You're going to go on to what will be incredible careers. I look forward to seeing that roll out. For some of you, I certainly hope that includes a career in academia, potentially in research. It's pretty rewarding. You might hear a little bit that it takes long hours, and that's okay because medicine's going to take long hours anyway. So seriously, I hope some of you find the research bug and decide to take on that as an aspect of your career. And finally, I just want to recognize some people who've worked very hard on the Embark program. First of all, our founding dean, who's not here today, Bob Fulberg. It was his vision. He envisioned the Embark program when he got here to create a curriculum that would expose all the trainees to research as they go throughout their medical school curriculum, to let them learn those skills, adapt those skills maybe to their clinical practice, evidence-based medicine, and to the two mentors who've now taken it on and turned it into something really unique, Dwayne and Kara. So I want to thank them very much for what they've turned this into, and again, congratulations to all the presenters. I wish I could sit here through the presentations. Unfortunately, I can't. And congrats to everyone who's been working in the Embark program. I look forward to seeing you in 2 years when you're on the other side of this thing. So have a good morning.
Thank you. For those who don't know, all the students had to give an oral presentation back in March to panels of judges. And from the feedback we had from the judges, we've chosen 10 finalists to present today. They've been invited back. Now, sometimes I think students think we do this to make life hard for them, but there is an educational purpose behind doing oral presentations. First of all, we hope that all your projects will be successful and that you will go to conferences and present your findings to specialized audiences. And often you can do that via an oral presentation. But also, you're about to enter your clinical years and you'll have to do lots of oral presentations. You'll be sent to assess patients, and then you have to go back and present your findings to the clinical team. And you'll be doing that all through your clinical years and into your residencies. So being good at oral presentations is a skill you must master. So that's why we really do it. Okay, the format of the morning is that each presenter will have about 9 minutes. 5 minutes to present, and then there's 4 minutes for questions and answers and comments, and for the judges to fill in their remarks and handover. Now, for the presenters, the most important person in the room is sitting here. Her name is Julie Strong. She's your timekeeper. So, when you've got 2 minutes remaining, she'll hold up the sign which says 2 minutes remaining. And when your time's up, she'll hold up this sign which says time's up. Now, if you see the sign, it doesn't mean you have to stop dead, but you do have to wind up within 10 to 15 seconds. If I have to come and stand right beside you, that means you really should stop. And if I take the microphone out of your hands and push you off the stage, that's another hint that you really should stop. Okay. All right. A reminder to the students in the audience, you have to give feedback to some of the presenters, and the links for that are on the Moodle site. Okay. Would our first presenter like to come up? Please welcome our first presenter, Jessica Barnes. Thank you.
Thank you. All right, well, good morning, everyone. My name is Jessica Barnes, and today I'd like to talk to you about my research looking at infection treatment of homeless and non-homeless populations in United States emergency departments. So why am I talking to you about this today? Well, the literature is quite clear, and that homeless populations use emergency department services at a disproportionately high rate. On top of this, they face higher rates of infectious diseases compared to their housed counterparts. Interestingly enough, though, there's currently a gap in knowledge within the literature on the care that homeless persons receive for these infectious diseases once they present to an emergency department. And this is problematic because there is data out there to suggest that for homeless persons presenting with an infectious disease to an emergency department, they have poor health outcomes in the long term compared to their housed counterparts. We wanted to fill this gap in knowledge, and we sought to do this by asking the question, is there a significant difference in emergency department infectious disease treatment for homeless persons compared to their housed counterparts? We defined treatment as diagnostic services provided, procedures performed, and medication class prescribed. And we moved forward with the hypothesis that yes, there is a significant difference that exists between these populations. Now, in order to answer this question, I utilized the National Hospital Ambulatory Medical Care Survey database. And since that is a mouthful, it's commonly referred to as NHAMCS. Now, what this survey has done is created a repository of data that spans over 2 decades. They collect data from hospitals in all 50 United States and the District of Columbia, just excluding Veterans Administration, federal, and military hospitals. I specifically am looking at the years 2007 through 2010 due to a readily available, pulled, and clean data set. And within my data set, I have over 139,500 data points, so it's quite expansive. I'm utilizing a retrospective cohort study design, and I began by creating variables for homeless persons and private residence persons, that being how we defined non-homeless for this study. I then created a variable for infectious disease cases according to the ICD-9 manual, and I pulled these cases out of the data set as a whole. I then compared my 2 populations via a complex sample logistic regression analysis for my variables of interest, and this allowed me to generate an odds ratio to compare my 2 populations. What we have found thus far, looking at diagnostic services and procedures performed, is that compared to private residence individuals, homeless persons have 13.59 times the odds of receiving sutures or staples when they present to an emergency department with an infectious disease. Interestingly enough, if you look at some of the other variables that we've looked at so far, such as liver function tests, imaging, incision and drainage, etc., we have not found a significant difference in any of those. So where does that leave us on the project thus far? Currently, the diagnostic services and procedural analysis has largely been completed. That means I am currently looking at the medication class prescribed. What that means is that I'm writing an extensive amount of syntax to create variables that are accurately collecting information we need for our specific aims. And once that's completed, I will then run analysis on those. And of course, I have run into some limitations and challenges along the way. For example, I have caught some errors within the data set I've had to go back and correct. And also, just because I did not personally collect this data, there's an inherent lack of familiarity with it. And both of these factors have lengthened the project time a little bit from what we originally projected. However, I sought to minimize this by seeking assistance from my collaborators at every step of the way. Thus, What we have found on this project so far is that a difference in management of homeless persons seeking infection treatment in United States emergency departments does exist. And really, this provides a platform for continual research, not only for myself, as I aim to identify a difference in medication class prescribing, but also for future research, potentially looking at more recent data, such as the years 2011 through 2015. And it is our hope that it will provide a basis for a more informed treatment of homeless persons presenting to emergency departments with an infectious disease. Here are my references for your knowledge. I would really like to thank all of my mentors on the project, especially Dr. Tracy Taylor, and all of you for your time. And I'm open to any questions.
Hello, we mic for any questions, comments?
Of course I have. When you went through the database, I've got two questions. Do you know
Absolutely.
how they identified homelessness, and what was the relative number of homeless patients as compared to those in a residence?
Yep, absolutely. So the survey is actually administered by employees within the emergency department via an automated form. And so I believe that they ask the individuals when they take them into the emergency department. They have categories for homeless, private residence, nursing home, etc. And then it's documented that way. And so I mentioned I'm using a complex sample. So when you scale up with the strat plan to do the complex analysis, there is about 265,000 individuals who both are homeless and have an infectious disease, which is relatively small part of the entire population, but given that that's such a large sample size, we didn't really see that it was an issue.
Thank you.
Yep, you're welcome.
Any more comments or questions?
Thank you very much. Could you please elaborate about this relationship of the sutures and the infection?
I'm sorry, could you repeat that?
Could you please elaborate on the relationship you found between being more likely to receive sutures for an infectious disease?
Yeah, so we found that for individuals who were both homeless and had an infectious disease, they had higher odds of receiving sutures or staples. As far as the meaning behind that, kind of my interpretation right now is that maybe as an emergency department physician, you're concerned about what that individual might be exposed to once they leave the emergency department. So perhaps they have an open wound or something and they're going to be exposed to other pathogens or the element. We're thinking that maybe they want to adequately prevent that, and so they might be more likely to provide sutures or staples for these individuals. But since we're right now kind of in the phase of just running the initial tests, we haven't really discussed that, but that's kind of just my preliminary interpretation of that, if that makes sense.
Okay, thank you.
Thank you.
Our next presenter has actually just changed her name. Congratulations. Please welcome Brianna Namukoa.
Thank you. All right. Hi, everyone. As previously stated, my name is Brianna Namukoa, and my project is on medical students' responses to complex ethical challenges encountered during global medical experiences. So before I jump into my research, I want to tell you a little bit about why I care so much about this project. So this is me in Uganda, and as many of my classmates know, before coming to medical school, I spent 2 years working for a mental health NGO in Uganda. And through that experience, my eyes were really open to some of the ethical challenges that you can encounter when working in a country that's not your own. For example, my team dealt daily with questions of justice and how can we allocate a very limited number of resources and services in as equitable a manner as possible. Additionally, while in Uganda, I met this wonderful man here, who is my husband, Peter. And Peter is a social worker and previously worked in Uganda for many different American agencies offering services in Uganda. And through his experience, he really got to see the good, the bad, and the ugly of what it looks like to offer services in a country that's not their own as well. Dealing with issues of possibly not treating local staff in the best manner, or how these agencies interacted with the communities that they're working with. So Peter and I have made it our combined goal to eventually move back to East Africa, and hopefully we will be ethical global citizens at that point, and our services will be offered in as ethical a manner as possible. So it's my goal that my training here at OUWB, for myself and any of my other classmates who are going into global service, will prepare them to be ethical global practitioners. Whoa, sorry. So sorry, everyone. Okay. So my project is addressing a gap that currently exists in the literature. It seems that a lot of literature recently has focused on how can we prepare medical students to be culturally competent, and is that even possible? Additionally, much research has focused on safety concerns that exist when you send American medical students to another country. But not much research has looked at the ethical considerations that need to be taken into account when medical students are in a country that's not their own. And you might be wondering what I mean by ethical considerations. So these are things like medical students being asked to do things above and beyond what they would normally be asked to do in American settings. Additionally, dealing with issues of donations or issues of corruption in the country they're operating in. So in this study, I'm hoping to examine OUWB medical students' ability to recognize these ethical issues and respond to them appropriately. I'm also wondering how we can improve preparation here at OUWB for students. And that includes looking at the MHCB program that we all know and love, and additionally looking at the pre-departure training program that exists for OUWB medical students who go on OUWB-sponsored rotations. So to meet these goals, I'm going to conduct 12 to 15 semi-structured interviews with current or previous OUWB medical students to gain input about their global health experience. I'll transcribe these interviews, and then I will code and analyze them using in vivo software. So currently, I am in the process of submitting my IRB. And the reason I'm not quite as far as some of my other classmates is I ran into challenges early on in conceptualizing this project. I really wanted to add something to the literature that was meaningful. So I think my goals were originally quite large in conducting a very large systematic review that was not quite feasible in the 4 years that we are here. So I have worked a lot with my mentors to refine my goals into what we have now, which we believe is both meaningful and accomplishable within 4 years. So in conclusion, this project is all about ethical improvement for global engagement here at OUWB and beyond. We hope that the findings we have here will change the curriculum, improve it if necessary here at OUWB, but also that our findings can be applied to other U.S. medical schools. So references, and a huge thank you to Dr. James Grogan, Professor Rachel Jaskowitz, and Dr. Wasserman as well. And thank you to all of you.
Comments, questions?
This is kind of a broad question. You might not be able to answer yet. But what do you foresee, like, we'd get a training on situations and that would hopefully prep us? Or, like, what do you envision that this could be within MHCB or beyond?
Yeah, that's a really good question. I think that we're not at a place right now where we can answer that question, but my hope is that we find out a lot of great information from the people we interview on if what we have is substantial enough and on what their needs are, and then we can present that to MHCB faculty and administration to see what they come up with as far as if changes are needed.
You say you're going to use NVivo. Can you
Yes.
tell us a bit more about that and how it works?
Sure. So NVivo software is a qualitative software. You input all of your transcriptions that you have, and then you can do both inductive and deductive coding techniques, which means you can come up with a code book beforehand and apply that to your data, or you can do line-by-line coding to come up with your codes as you go. So it's a really great versatile software, and it combines all of your codes so that they're easy to analyze in the end. And we like that approach because we are doing both inductive and deductive coding techniques, meaning that we have predetermined different ethical challenges that we're already looking for based on previous research, but we're also looking for new information to come out of the data.
Any more comments or questions? Anybody in the audience can ask. Okay, well, thank you.
Thank you.
Our next presenter is Victoria Greenstein.
Good morning, everyone. My name is Victoria Greenstein, and I'm presenting my Embark research, bibliometric analysis of interdisciplinary collaboration in cancer immunotherapy research from 2010 to 2018. Traditionally, we've looked at cancer based on its anatomic origin. We treat breast cancer differently than lung cancer or colon cancer. And by that model, physicians and researchers have specialized in particular cancer types, like skin cancer or genitourinary malignancies. With the advent of new technologies, we've moved into a molecular model of cancer therapy. This allows us to identify actionable biomarkers using genetics, proteomics, and immunohistochemistry, and find mutation-specific targeted therapies to more precisely target cancer, rather than just inhibiting global cell growth. By finding these markers, we're able to change the model of cancer therapy. For example, Herceptin is a drug that targets HER2-positive breast cancer and has dramatically improved outcomes for patients with this type of cancer. As a result of this model, researchers have had to identify novel clinical trial designs in order to operate within this new molecular model. One such example is the basket trial. A basket trial utilizes the inclusion criteria based on a biomarker instead of an anatomic origin in order to determine who's eligible for a clinical trial. This means that the clinical trial for a drug could include patients from a variety of different cancer types that all share the same biomarker. This fundamentally has changed the way we look at clinical trials for cancer treatment. And nowhere is this used more than in the field of cancer immunotherapy. Instead of directly targeting cancer cells, cancer immunotherapy seeks to mobilize the immune system to indirectly target cancer cells that have a specific biomarker. This requires a highly interdisciplinary approach, building on the expertise of basic science researchers, clinicians, and pharmaceutical companies in order to create targeted therapies that work to directly target the cancer cells themselves based on the biomarkers that we've discovered. The field of cancer immunotherapy has grown tremendously since 2010. And in 2017, there was a turning point where the FDA approved the drug pembrolizumab, or Keytruda, for any unresectable or metastatic solid tumor based solely on a biomarker instead of the tissue type. This was the first time that the FDA approved a drug based on an indication of a biomarker. This completely changed the way we look at cancer therapy, and it results in a paradigm shift in cancer treatment. But we can't just say that there's been a paradigm shift. We have to prove it. And in order to do that, this project applies bibliometric techniques and social network analysis in order to determine collaboration patterns in cancer immunotherapy research. What we'll do is we'll create a network diagram such as this one, where each node represents a researcher, and we can see how researchers collaborate and are connected based on the connections between these nodes. We can then quantify and measure collaboration over time and space. We hypothesize that cancer immunotherapy research will show tissue-specific research clusters with increasing collaboration as measured by the connections between these nodes over the course from 2010 to 2018. To do this, we'll use a two-step approach. First, we'll do a literature search of cancer immunotherapy research using databases, and we'll identify the relevant research in the field. Once we're there, we will use the results of this literature search as our data set to map it using specialized software such as VOSviewer and HistNet Explorer in order to create co-authorship and co-citation networks to measure collaboration. I think it's easier to go through an example, so let's walk through some preliminary results. we did a single database search of the drug pembrolizumab and its associated search terms and found nearly 2,000 results. We then used those results and analyzed them using VosViewer, the specialized networking software. And we created this diagram of the mapping cancer immunotherapy research of pembrolizumab. And we mapped this by site. What we were able to do is we were able to identify 4 distinct research clusters: melanoma, skin and metastasis, or the current indications of pembrolizumab, lung cancer, other primary tumors, and basic science research. By doing so, we can see how these clusters are connected, and what we plan to do is see how that changes throughout time. By applying this technique, we can measure the collaboration and see the development of the field of cancer immunotherapy. But when doing our preliminary results, we also identified some problems, mostly limitations of the software. For example, the software uses indexed keywords, so we'll have to go in and add our own keywords using either a script that we create or a new type of or using manual coding of these terms. Ultimately, we hope that this research will help enrich our understanding of the field of cancer immunotherapy and allow us to identify opportunities for future collaboration to better serve patients. And I'm happy to take any questions.
Comments, questions?
I actually had 2 for you, if that's
Sure.
okay.
Bring 'em on.
On that one figure you showed, you had tumor cell line and cell line tumor. What's the difference between?
Excuse me?
You have tumor cell line and cell line tumor.
So this represents one of the limitations of the software that we were using. So the software VosViewer uses indexed keywords from PubMed or other databases. So in this case, tumor cell line and cell line tumor were separate keywords, and so they were indexed differently. So that's one of the limitations that we identified within our preliminary search.
Okay. And then my other question is, so you have like basic science, primary tumors, lung, melanoma, et cetera.
Yes.
How do you define basic science? So if someone is working, just trying to make sure I understand this, if they're working on, say, a biopsy from lung, that's not basic science? I was a little confused on that.
That's a great question. The definition that we have from basic science is just kind of the overall view of what was within that cluster. When we really delved into what was included here, it was mostly based on cell lines instead of human tissue samples within like clinical trials. So it's kind of depending on where you are within the research workflow. So whether you're working in the lab on cell lines that are established that other researchers can use, or you're working on actual patient samples. And most of the things that you'll see in the red, green, and yellow research clusters are based on like clinical trials from human samples instead of cell lines.
But if you're a researcher working on patient samples, that would go under what? That's what I'm trying to figure out.
I'm not sure we're able to distinguish that at this time, but that is a great thing that we should look into in the future.
Are there any particular immunotherapies that seem particularly promising?
There's a lot of them. Pembrolizumab is actually one. It has showed promise in a variety of different cancer types, including colon cancer, lung cancer, melanoma. It's made a huge impact in melanoma, particularly metastatic melanoma, which used to have an abysmal outcome before the advent of cancer immunotherapy. Anything else?
Okay, no more questions. Thank you. Okay, judges ready? Our next presenter is Alexis Curl.
Hello, I'm Alexis, and I have been working towards revealing the tumor microenvironment response to various radiation therapies. To begin, we as a scientific community have done so much research on the physics of radiation, it's amazing. We have several different modalities now. We can use high-energy X-rays, gamma rays, charged particles. We can use external beam, and the instrument here you can see can do full 360 around the table to target any point of cancer within the body. Additionally, we also have internal therapy. However, we don't exactly know what the radiation is doing. Certainly, we understand that the radiation is inducing DNA double-stranded breaks, which is most effective on cells that are rapidly dividing, which is why it works so well against cancer. But beyond that, we don't know precisely what is happening. And that's because the tumor microenvironment is extremely complex. It's kind of like a bag of mixed marbles. You got every different size and color combination you can imagine. In this environment, we have tumor cells, endothelial cells, macrophages, lymphocytes, extracellular matrix, which in itself is quite complex, as well as hematopoietic stem cells. A previous lab member of mine showed that these stem cells are actually migrating from their origin within the bone marrow to the point of radiation therapy. And then through cell tracking, they found that these stem cells are differentiating to become monocytes, which then further mature to become macrophages, of which they can become either one of two different lineages. They can become an M2 macrophage and have roles in tumor promotion, such as angiogenesis, or they can become an M1 macrophage and have roles in tumor suppression, such as immunostimulation. So imagine if we could somehow drive these stem cells to become M1 macrophages. We could induce the body's own natural self-defense mechanisms against cancer. Imagine what that would mean for your patients. Perhaps a little less chemotherapy, a little less unwanted side effects, and overall improved quality of life. Here's the experiment I've been working on. We began with 3 cohorts of mice. We injected them with Lewis lung carcinoma cells so that they would grow a cancerous tumor. And then we gave them various radiation therapies. The first cohort, we gave them a single standard beam of radiation therapy. The second was pulsed radiation. We tried something a little bit different. This is as if you had 5 M&Ms and you ate them all at once. That would be your standard therapy. Compared to pulsed would be as if you had 5 M&Ms and you ate them one at a time. Overall, the therapy is the same. However, it's just delivered a little bit differently. And then our third cohort was our control group that did not receive therapy. Afterwards, we excised out these tumors so we could study the microenvironment. And here's what we found. INOS is a marker for those M1 macrophages, the ones that we want to be there, the ones that are immunostimulatory. And if you can see here, the standard radiation group compared to the no radiation group, the M1 population is quite depleted, which is not exactly in our favor. However, if you go ahead and look at the pulsed radiation group here, you can see that our M1 population is still very much there, which is exciting for us. Again, if you look over here, you can see the tumor volume versus days post-treatment, essentially the growth rate of these tumors. The non-irradiated group, in the black squares, you can see it has a rather steep growth rate. The standard therapy in the white circles has a decreased growth rate, and even more excitingly, the black triangles, our pulsed radiation group, has an even slower tumor growth rate, which is exciting for what it could potentially mean for our patients. So my future directions include looking into this tumor microenvironment a little bit more in depth. We're going to be doing RNA sequencing analysis so we can look at the upregulation and downregulation of genes between these 3 different cohorts. And then we're going to validate our data using PCR, Western blot, immunohistochemistry, And then after we get a better understanding of what's happening, we're going to do some in vitro work and look at the role of endothelial cells on the cancer environment. Thank you.
Previous questions?
Hi.
Hello.
Hi. I just had a few questions for
Definitely.
you. Because I was curious. So when you went to your data, how many times have you done that? I didn't see any error bars or anything.
Yes, so this was just an N of 1 so far.
Okay.
The project is actually quite more complex. We're actually looking at different time points. So we've got an N of 3 for day 3, day 6, day 9, and day 12 post-radiation. So this is just a quick blip, preliminary data, so that I could squeeze it into a 5-minute talk. I apologize.
No worries. No. And then when you were talking about what you guys are going to look at in the
Yeah.
future with the tumor environment, so with your RNA-seq analysis, you're going to get a lot of data because there's going to be a lot of different cells in there.
Yeah.
How are you going to deal with that?
So there's going to be the RNA sequencing analysis, the company that we're going through, we're going to be looking at targeted genes to see how they're upregulated and downregulated. The macrophage population is definitely one of the ones we're looking into most. We can also use flow cytometry to kind of pull out the cell types that we're interested in and kind of isolate those down a little bit. But we want to look into several different things, like the extracellular matrix perhaps could be one of the things that are inducing the macrophage differentiation. There's so many different variables. It's going to be a huge project, and we just got to take it one step at a time.
Just keep in mind that some of those genes that you find upregulating macrophages will go up in other cells too.
Okay.
So
Thank you. I will definitely keep that in mind.
Any more comments or questions?
Hey. I can't quite see your chart because I'm behind the podium.
I'm
So just
sorry.
a quick, oh no, it's not your fault. My
Yeah.
fault for choosing to see. The INUS expression,
Yes.
is that done doing like RNA-seq, or how did you quantify, what method did you use to quantify the expression?
So what we did was we extracted the mRNA, converted it into cDNA, and then looked at the expression. So.
We can't take questions from the back. I need the exercise. Yeah?
So I was wondering,
Yeah.
I feel like I just want to hear you say it, I guess. It looks like we could use the macrophages that are basically going rogue and causing problems to potentially limit like side effects from radiation, right? Is that correct?
Kinda. So the macrophages, they're going in two different lineages, right? The radiation may or may not have a role. I'm just showing you a blip of the M1s. I really need to look into the M2s and see how the radiation is affecting those as well.
Okay.
So, yeah.
Okay, thank you.
Thank you.
Okay, thank you. Please welcome our next presenter, Alexandra Ransky.
Okay. Hi, everyone. As Dr. Loftus said, my name is Alexandra Ransky, and the title of my talk is Intravitreal Thrombolytics as a Novel Treatment Option for Central Retinal Vein Occlusions. So the vasculature of the retina is composed of two primary vessels, the central retinal artery and the central retinal vein. Retinal vein occlusion is a disease that occurs when there is a blockage in the central retinal vein here or its branch points. And if this is left untreated, it can lead to retinal ischemia, neovascularization, hemorrhage, macular edema, and ultimately vision loss. So there are a number of treatment options available for this disease. The standard therapy includes intravitreal anti-VEGF, intravitreal corticosteroids, and panretinal photocoagulation. A single patient could receive one or all three of these treatment options depending on the severity of their disease and response to treatment. But the problem with the standard therapy is that it does not directly target the cause of the disease, and a single patient is likely to receive multiple injections for an extended period of time, sometimes for the rest of their life. So in recent years, intravitreal thrombolytics such as TPA have been identified as a potential treatment option that will directly target the cause of the disease and lead to better patient outcomes and a reduced need for injections over extended periods of time. So why do we care about this? Retinal vein occlusion is the second most common retinal vascular disease after diabetic retinopathy, and it's a potentially devastating disease for your patient. The standard therapy only targets the symptoms and is therefore not a cure. A number of studies have given us reason to look further into the efficacy of intravitreal thrombolytics. In a recent in vivo study done in a porcine model, it was shown that TPA has the ability to cross into the retinal veins, which suggests that it could directly target the blockage. And in a number of pilot studies done in human samples, there was success seen, but they were unable to draw strong conclusions, and they do recognize the need for further studies to be conducted. And something that was really personally motivating for me was one amazing case that was seen at Associated Retinal Consultants. A patient presented with sudden unilateral vision loss and had their vision returned to 20/25 just 3 weeks after receiving treatment with TPA, which is absolutely amazing. So our prediction is that patients receiving intravitreal thrombolytics will show improved visual acuity, improved macular edema, and a reduced need for injections over time compared to patients who are receiving anti-VEGF or corticosteroid monotherapy. So our treatment is a retrospective chart review looking at patients who were treated at Associated Retinal Consultants between 2013 and the present. The charts are being categorized based on treatment that patient received, and multiple variables are being collected with special focus on visual acuity, macular edema, and the number of injections they received. So visual acuity and macular edema measurements are being looked at multiple time points, those being 1 month, 3 months, 6 months, and 1 year post-treatment, and number of injections received over time are being looked at 6 months and a year. And our data are going to be analyzed using a 2-sample equal variance t-test, and our variables will be accounted for using a linear regression. So here are some results looking at 8 total patients, 4 from each treatment group. And I would like to draw your attention to this graph here. I think it's on your bottom left. Changes in visual acuity in patients who are treated with the standard therapy are shown in blue, and patients treated with TPA are shown in orange. And you can see that patients being treated with TPA actually did have an improved visual acuity over time, which is promising for us. However, our current data are not statistically significant, and our standard error of the mean is large, which tells us that we do need a larger sample size. Therefore, the further steps in my project are to collect more data. So unfortunately, our project does have 2 limitations that cannot be addressed. The first are the limited number of patients actually being treated with intravitreal thrombolytics due to its novelty. And second are the common complications or challenges that come along with a retrospective chart review, such as having multiple variables that need to be collected and controlled for. So in conclusion, central retinal vein occlusion is a common and serious disease. The standard therapy has its limitations, and intravitreal thrombolytics do warrant further study. It is our prediction that patients using intravitreal thrombolytics will show improved treatment outcomes, and it is our hope that this study can provide further support for a more controlled and randomized trial. Here are my references. And I would like to thank my 2 mentors and everyone who has provided support to me over the past 2 years at Oakland University, and of course all of you for listening today. And at this time, I can take any questions you might have. Thank you.
Comments,
Mallory
questions?
has a question. In the back there.
Hey, I was just curious, what would be your indications versus contraindications for receiving the thrombolytics?
Sure. So it typically depends. It's actually really complicated. It has a lot to do with clinical reasoning and whether you think that the risks or the benefits are going to outweigh the risks, because obviously there is a risk that comes with injecting intravitreal thrombolytics, such as hemorrhage. So I believe that physicians will typically look at the age of the patient, again, whether they think the benefits are greater than the risks, and then just how severe their central retinal vein occlusion is and how damaging it is.
I may have missed it, but how are these administered?
Oh, it's intravitreal injection, so just right into the vitreous of the eye.
How easy or difficult is that to do?
Well, I've never done it. But it seems like that they will numb the patient's eye with a local anesthetic, so I imagine it's not terribly uncomfortable for the patient. It is something that if they're getting the typical anti-VEGF or the corticosteroids, I mean, these patients have to come into the clinic pretty much monthly to have these injections. So I imagine it's a tolerable treatment. And I mean, these physicians are obviously really experienced, so it's something they can do fairly quickly.
So it's done under local anesthetic? Yeah.
Yeah.
Mm-hmm. Okay. Any more comments or questions? Okay, thank you.
Okay, thank you.
Please welcome the next presenter is Nikki.
That's fine. Can you guys hear me okay? Yeah, okay. So before I start my presentation, I just want to show you a quick video clip. And so you're going to be watching a gymnast do a skill on the vault. And I want you to try to figure out like what's wrong with this video. Okay, there you go. It was really quick. If you blinked, you missed it. So although the problem isn't actually visible, it's very significant in the gymnastics community, and that problem is urinary incontinence. With the permission of that gymnast, I'm going to disclose with you guys that she actually experienced urinary incontinence while performing that skill, and she experienced it about 3 to 4 times a week during gymnastics practice. So because of that, I've developed this project determining the prevalence of urinary incontinence within the female gymnastic community in the United States. So why does this matter? Well, for starters, this is very embarrassing for these girls. There is a lack of research on this topic, especially about the long-term side effects that this poses on their health. If you have consistent acute urinary incontinence, how is that going to affect you later on in life? Are you going to have chronic urinary incontinence? This is an inconvenience for these girls, and it decreases their quality of life. I know a handful of girls who have quit gymnastics altogether because of this. This is highly prevalent in the community, which you'll see as I show you raw data from our study, and there's stigma and taboo associated with this. That makes these girls so uncomfortable that there are actual podcasts online for these girls to refer to find strategies on how to decrease their leakage while they practice. Now, something that should be of concern to all of us is that one of these strategies is that they're advising these girls to not drink water during practice to prevent them from leaking. These girls are practicing anywhere between 6 to 9 hours a day. And so if they're practicing that much and they're not drinking water because of this, then this is something that we need to address. So here the problem is a little bit more evident. This is a French gymnast. Her name's Emily. She was actually doing a routine for world qualifiers in Australia when a photographer captured this unreal perfect moment. And she's actually a very world-renowned gymnast, and a lot of young gymnasts look up to her. And so when they saw this, instead of being praised for her abilities, she was ridiculed, which did two things for the gymnastics community. It made these young girls realize that, one, they weren't the only ones who experienced this, and two, that this is something that they should be embarrassed about, because society doesn't know that this is a common thing in the community, and it's something that can be used against them, essentially. And I also want to point out that this is actually on Getty Images, so this is a stock photo. So one of the main purposes of this project is to bring awareness to this issue in hopes to kind of decrease the stigma associated with urinary incontinence in the gymnastics community, and hopefully increase conversation about it amongst these gymnasts with their teammates and their coaches to hopefully alleviate any embarrassment that they feel. So we want to first address the prevalence and compare it to an age-matched control group, age and gender-matched control group, and basically investigate what kind of skills in gymnastics, what events elicit the most leaks. And important for the community, we want to understand where this issue lies in conversation to kind of see where these girls are in terms of how they feel about talking about this with one another. And of course, we want to remedy the literature gap because there isn't research on this, really. This is really important for the community, and we anticipated to see a very high prevalence, which we'll see with the data. So basically we developed a survey. It looks something like this. We asked the girls if they've ever experienced a leak during gymnastics, how many times they experienced it, if this was something like once in a lifetime or like once a week kind of thing. We asked them what events they experienced it more on and how comfortable they were talking about this amongst each other and with their coaches. And lastly, this question is very important. If there was something that would decrease their frequency of leakage, and if there was something that would decrease that, if that was something that would interest them. So we were concerned that we weren't going to get a lot of responses because of how sensitive this material is. So we provided compensation for these girls. We collected our data, and we're in the process of analyzing our data right now. So we ended up getting 200 responses, and of those 200, 96.5% of these girls reported leaks. That is huge. And this isn't something that's happening to them once in a while. This is a once a week kind of thing for them. And basically, we also determined it happens most on spring floor, which is going to be useful when we develop more studies. Most of these girls are uncomfortable talking about this with their coaches, families, teammates, and over 86% of girls report this as a problem in their life. Almost a quarter of these girls report this as an extreme problem. So in conclusion, we saw this, we found a very high prevalence in the community. We anticipate that distributing the survey would increase conversation amongst these girls and hopefully decrease the embarrassment and stigma associated with urinary incontinence. I personally hope to develop more studies in the future assessing the severity of the problem and investigating the potential long-term effects. I know the gymnast in the first film, she told me she is retired. She's been retired for about 6 years. She experiences urinary incontinence in her daily life that she attributes to her practices as a gymnast. I also want to study the effects of pelvic floor strengthening exercises. That's a lot to do, but we'll get there. I am now open to any questions.
I apologize if I missed this, but how do you identify which girls you distribute the survey to, and then how do you get the survey to them? Like, is it via email or?
Right, that's a great question. Thank you, Jessica. So basically, I coached gymnastics for about 6 years, and that's why I wanted to do this study. And so I just distributed the survey via email to some coaches that I knew and some ex-gymnasts, and then they kind of sent it to more gymnasts and more ex-gymnasts, and then it was just kind of a domino effect. And then it kind of became like big news in the community. Like, I was getting emails left and right from girls saying, like, we got your survey, we're so excited about this, like, thank you for bringing this up, like, this is a huge deal. So these are some girls that I used to coach too.
So I was wondering if you collected data on like age groups and if it's more prevalent in certain age groups, and then if it gets worse over time as well.
So that's a good question. So we only distributed the survey to like gymnasts above the age of 18, so we wouldn't have to worry about child's like IRB stuff. But we also recorded the age of first leak and like their current age right now, and most girls start leaking at the age of 7. And they experience leaks up until like the age of 30, and then after that, once they stop practicing gymnastics, I've gotten a lot of comments from these ladies that they still experience leaks in like daily activities, like with sneezing and coughing, and they shouldn't, because these are like very athletic girls. We also asked them if they've ever given birth or had ever been pregnant or anything like that, and they haven't. So this is like an anomaly, basically. Yes. No, it actually doesn't.
Because boys do some of the same.
Yeah, no, that's a very good question. So when I was coaching, I just like word of mouth, I would just ask people here and there, like, do you guys experience this? And like our guy coaches would be like, what? You guys pee? They're like, we never knew that. We're like, yeah, no, it happens to like almost 96.5% of these girls.
Hi, have you identified like a particular thing in training that causes this, or like the type of training that can maybe be altered to change this?
That's like a great question. So that's like the kind of stuff that I want to research like after the study. So before we can like fix the issue or identify what's like really causing it, we have to first like acknowledge that this is a problem. Like nowhere in the literature, well, barely, there's probably a handful, and it's like global, stating that this is a problem. But from the research from the data that we collected, we found that high impact, so on spring floor, on vault, anything that causes an increase in intra-abdominal pressure causes these girls to leak, and actually causes like weakening of their pelvic floor. So hopefully in the future we'll investigate more.
I know you said you're age matching these girls, and I know you sent out a survey to us in the medical school. Is that who you're age matching them to, or other populations as well?
Yes, so our age match is OUWB female students between the ages of 18 to 30. We chose OUWB female students because we're not the most active, especially compared to competitive gymnasts, so we thought that would be a good control.
Last question.
I was just curious, have you looked at other females doing sports that put similar stress on the body and look at like as a control?
So when I was looking at the literature, I did some reading on like female soccer players, track and field, professional like weightlifters, power lifters, stuff like that. And there was actually a lot of research on female power lifters and soccer players, but there wasn't much on gymnasts, so I just wanted to bring this to the surface. But yeah, it happens to a lot of high impact athletes.
So it seems I'm not the only one who needs exercise. Okay, please thank our presenter.
Thank you.
Our next presenter is Ariana Shack. Please welcome her.
Hi everyone, so my name is Ariana Sharak. I'm a second-year medical student if you don't know me. And my project is called Understanding Opioid Addiction in the Chaldean Community. So I'm sure you're all aware, so I won't go on it. There is an opioid epidemic currently happening. 130 Americans die every day from opioid overdose. In 2017, 40,000 Americans died from opioid overdose, and something alarming is that synthetic opioid overdoses are on the rise, and I'm sure you've heard of this in the media. It's big in legislature right now, so we have a problem. So why did I want to do this study? So there's a big gap in the literature. There is nothing currently on opioid addiction in the Chaldean community in the literature. There is stuff on opioid addiction in the Arab community and in the Catholic community, but because of MHCB, you all know what a Chaldean is, and you know that Arab studies will not get at the religious component because there are a multitude of religions in the Arab community, and the Catholic studies will not get at the cultural component. So we need to do a more specific study on this community. It's unique to this area, so that's great. I'm also Chaldean, so I'm a little selfish of why I wanted to do the study. So our objectives were to assess the knowledge, attitudes, and beliefs of Chaldean community members on the opioid epidemic. So what did they think about it? Did they know about it? And then we wanted to identify if there was a need for resources, what would the community want if we were to develop something. So what we did was we designed a Qualtrics survey, and then we contacted Chaldean Facebook groups, so Chaldean Moms of Detroit, Chaldean Men of Detroit. They disseminated our survey for us, and then we asked about 4 key questions. So your demographic information, so what type of schooling did you have, your gender, and then awareness of the crisis, so do they think it's a problem in the community, were they aware of it, and then their opinion on it, so did they think it was a moral failing, did they think it was a sin, did they think it was a disease, and then we asked about their knowledge of available treatment and what types of things would they want. So we have some preliminary results. At the time we ran the data, we had about 170. We have a little bit more than this now. The average age was 32, and 75% of responses were female, and that was because the biggest Facebook that sent out was the Chaldean Moms of Detroit, and they're super active, so I think that's why we had more females. So we had tons of questions and data, but I'm going to show you some data that's pertinent to future steps. So if you have any other questions, please feel free to ask me after. But we asked, do you think there's an opioid problem in the Chaldean community? 89% of people said yes, so we can see from community members they think this is a problem. So is there a stigma associated with opioid addiction in the Chaldean community? You can see 52% strongly agreed and 26% agreed, so the majority agree with this. And this is a big reason why I wanted to do this project, because just from my work in the community, there's just a huge stigma and it's a huge barrier to care for these patients. So this is a big, big problem. So we all learned that many Chaldeans are trilingual or bilingual. So we asked, what languages do you speak? 96% of people spoke English, 74% spoke Chaldean, and 45% spoke Arabic. So if we were to design an intervention, languages is going to be a key component that we're going to have to look at to incorporate in our interventions. This is really interesting. It was interesting to me. I don't know if you find it interesting, but if you or someone you knew needed help with opioid addiction, who would you go to for information and guidance? So the biggest percentage was physician or healthcare professional at 65%. 41% said inpatient or residential. 39% said nonprofit. We have a local nonprofit called Peter's Angels that helps Chaldeans with addiction, so that's probably what they were thinking of. And then 31% said faith-based support. So I was personally surprised because, like we learned, this community is a very religious community, so I almost thought that it would swing higher to the faith-based support, so I was surprised that physician was number 1. And then should addiction educational resources be translated into other languages? 96% said yes. So you can see that if we are to design an intervention, languages is going to be a key component to getting at the members of this community. So in conclusion, debating how much time I have left. In conclusion, our preliminary results showed that the community thinks there's a problem within their members. Additional resources are needed based on what they've told us. Translated materials are needed, and we need to improve and develop resources, particularly targeting languages. So next steps, we are still collecting our survey. I'm going to send out another round, try to get more responses. And then we're going to do our data analysis, and we met last week to talk about next steps. So what I would really hope is that we could have a pamphlet, and we would use the physicians kind of as a portal based on what the community has told us. And that would probably be in English and Arabic. When I went to the Chaldean Community Foundation, they said most people don't really read and write Chaldean, they mostly speak it. So a pamphlet would be in English and Arabic. And then we're hoping to do a trilingual naloxone training. This is particularly important because the work I did in the community, I saw lots of moms coming who didn't speak English, and the kits that talk to you are in English, and so I was just like totally distraught that like these moms who probably don't read English are coming in and trying to use these really crazy kits. So this is going to be super cool and important. We had a lower response rate than I thought because there's tons of Chaldeans, so why didn't they answer my survey? I'm not sure. And then we had the female response rate because of what I talked about. My references, and thank you so much to my mentors, Dr. Lergenfeld, Professor Yaskowitz, Patrick Carabon, who helps me with everything, and the Chaldean Community Foundation, who's helped me do tons of things. So thank you all.
I was wondering if in your early preliminary data, if you've found that there is a significant difference between some of the literature on the general population and your more specialized population that you're studying.
In terms of the prevalence?
The prevalence as well as the approach to, I know you had mentioned that you thought something faith-based may be higher and those types of things where they may look into getting help and everything.
That is a loaded question. I could go on for days. But I have not, in terms of prevalence, I haven't seen any difference because we don't have any literature yet on the prevalence in the Chaldean community. In terms of, I think maybe you're asking, like, because it's a more faithful community, do they tap into, like, religious resources more? I haven't seen any of that. I just personally thought, my mentor told me not to explain all of this stuff, so I'm not going to do it. But I personally thought that they would be tapping into like priests more than physicians, and just based on the data we have, I haven't seen that. But I can answer this question much more longer later. Does that answer your question? Okay, thank you, Matt.
In your survey, when you asked about languages, did you identify need in terms of like what the proficiency of the languages people spoke, in terms of like how proficient they were in English, and who specifically was like monolingual, bilingual, and trilingual?
Yeah, and we did ask about, I think we had a question too about like citizenship, and we had a question about like where you were born, so we were definitely trying to target that. But something I definitely want to do so that we make sure that that's not a problem is possibly create like a YouTube video that goes along with the pamphlet so that you can scan on the back a code and a video would pop up, so in case you don't read, the pamphlet could come up in a video in 3 different languages, because that's a big problem too. Like, my dad doesn't read and write, but he knows how to use his smartphone, and he could totally scan a code on the back of the pamphlet if it was explained to him. So yeah, thank you for that question.
So a language barrier is definitely evident. When you delivered your survey, did you deliver it in multiple languages?
We didn't, and that is the problem. That's something I wanted to say too, that we are seeing here people who have access to Facebook read enough to take a survey, and so it's like a very small, not a small population, but it's a particular population within the Chaldean community, and so that is an issue, and that's why I want to target, make sure we are cognizant that people might not read and write, and that they might not even speak English enough to take the survey. So we definitely have to cover all 3 languages and different types of portals, such as written and video form. Thank you.
Will the Catholic Church be a help or a hindrance in this?
Don't go into it? I'm going to go into it. Okay. We originally started off by surveying priests because we thought they're like the portal entry into the community. They're very highly respected. They could be very useful for this. And I got 4 survey responses. Really like dismal response. So we had to switch to surveying community members. So we are now going around to the Catholic Church to do this, if that makes sense. And it might be because, like my mentors think, that it might be like they have some duty to their parishioners that they can't speak about this type of stuff openly to other people, kind of like how we are with our patients, so maybe that was a contributing factor.
Any last comments or questions? Okay, thank you.
Thank you.
Okay, our next presenter, please welcome Bhavneet Singh.
Awesome. Good morning, everyone. So nice to see everyone here. My name is Bhavneet Singh, and my mentor is Dr. Haj Hussain. And our project focuses on comparing clinical outcomes between conventional versus Mako, unicompartmental knee arthroplasties. Now, that's a handful to say, but don't worry, there's an abbreviation, so bear with me. So, what is an arthroplasty? An arthroplasty is just a knee replacement. And there are two main types. A total knee arthroplasty, which is kind of taking out the whole knee joint, and unicompartmental knee arthroplasty, UKA, which is taking out part of a joint. And I'll explain the difference between these two in the next slide. And the most common reason why patients get knee arthroplasty is because of osteoarthritis. And I'm sure we just studied steps, so it's fresh in our mind. I'll just, do a quick brief through. So osteoarthritis is basically just a wear and tear of the knee joint as we age. And just to help you guys visualize this is a normal joint. As you can see, there's cartilage, there's synovial fluid, and the bones aren't touching each other. And with the histological image, we can see that it's kind of just one uniform color. It's purple, it's very basophilic, and that's signs of a healthy cartilage. However, when we look at osteoarthritis, we can see that the cartilage is kind of worn away, there's no fluid in between it, and the bones are touching each other. And when that happens, that causes extreme pain for the patient, and is the main reason why they want to get their knee replaced. And then the histo image, it kind of looks like a mess. There's an assortment of colors. There's white, there's purple, there's pink, and you can see some red in there, which is signs of blood, and you don't want to see that. And just to explain the difference again, we can see that with the UKA, only part of the knee joint is removed, and the TKA, you see this entire knee joint is removed and replaced with the component. And the reason we want to choose UKA compared to a TKA is because it has functional advantages. It's less invasive, it preserves the bone, and it's easier to revise if the surgeons want to go back in and fix something. But a major drawback is that it's really hard to perform conventionally because the surgeons have less room to work with. So Stryker, which is a surgical corporation company, they developed the Mako robotic assisted system, and some research has shown that it helps surgeons perform the surgery better, improves accuracy, component placement, and it helps the patients too. It's less post-op pain. All patients want to have less pain after surgery, right? And with this image right here, it's actually taken from Beaumont. And what happens is that with the Mako device, the surgeons are able to create a 3D image of the knee, and that helps them plan what they want to do with the surgery. It helps reduce the errors associated with it later on. So our research question is basically seeing how do the post-operative clinical outcomes differ between a conventional versus a Mako robotic assisted device? Because a lot of research has focused on, how is the surgery itself easier for the surgeons, but we also do this for the patients. So we want to see how they're affected between the conventional versus the robotic type. And some common post-op outcomes are the wound infection, anemia, and PE-DVT. So we want to see how these rates differ between robotic versus a conventional type. These are my materials and methods. We're going to do a retrospective study. The years are 2012 to 2015, and we're going to use data from the National Inpatient Sample Database, which is a huge database that collects information from like 100,000 plus U.S. community hospitals, and the data is de-identified before they put it into the system. And we're going to focus on participants 65 years age or older because a lot of surgeries are performed in this age group. It helps avoid age as a confounding variable, and on top of that, we found that it's more cost effective compared to a TKA. And this slide just shows my variables of interest, just for completeness. And the analysis, I haven't really met with the biostatistician because, a lot of stuff going on, right, with med school. But with my mentor, I'm planning to use descriptive statistics for each variable and chi-square tests for categorical data. The current status, I have received funding, and we anticipate that the patients who receive a Mako robotic assisted UKA, they'll probably have lower rates of post-op clinical outcomes with PE, anemia, and wound infection. The timeline, today is a colloquium, so here I am. I plan to meet with the biostatistician at the beginning of June 2019, which is like now, so after this, I have to probably schedule a meeting. And I want to analyze at least one variable by the end of June, end of the month, and then analyze the rest of the variables by the end of the year, and hopefully start working on my poster next year. All right, and some limitations. Surgical experience is one thing because I'm sure that newer surgeons who are, just come off of training from Mako robotic assisted device, they're not really as, well in tune to perform the surgery, so they might be more prone to making errors. And then also prior medical history of the patients. Those patients who have hypertension or, diabetes, high cholesterol, that might affect the post-op outcomes compared to people who don't have those conditions. And I haven't faced any challenges yet besides time management. Like I said before, we're busy in medical school. I just have to make sure I, balance my time properly because M3 and M4 year is going to get even busier. So I got to make sure I really hone down on this Embark project. The concluding remarks, the impact that we want to make. Basically, we want to help surgeons decide which surgery is better to perform, whether the conventional or Mako or UKA. Obviously, we want the surgeons to have a good experience to make it easier for them. But again, like I said before, we want to make sure the patients have a really good experience with the surgery. So we want to see which method is advantageous, which method has lower outcomes. And future research could focus on cost effectiveness and analyzing different clinical variables, such as length of time in the hospital and mortality rates. And then acknowledgements, I want to thank my mentor, Dr. Hussein. She helped me with our PowerPoint and with the histo images, and also to the Embark coordinators, Drs. Baxell, Loftus, Zerinsky, and Taylor for always putting up with my absence and all that stuff with deadlines and everything. So thank you guys. And my references, any questions?
Comments, questions?
Is there any difference in cost between these two surgical techniques?
That's one thing I wanted to look into. Looking at the research, I think like the Mako robotic assisted device itself is more expensive than the conventional, but if you look at it like long term with pre-op and the surgery plus like post-op management, it seems to be less expensive than the conventional type.
How come there's no orthopedic surgeon involved in the project?
My mentor is Dr. Hussein, and she does have connections with orthopedic surgeons at the DMC, so I have been in contact with them at the beginning of my project just to format everything, so I'll be in contact with them as I carry out this study. So, yeah.
I was wondering if you'll be excluding any patients based on comorbidities like hypertension, diabetes, obesity, post-operatively?
Yeah, that's great. So with the NIS database, they actually have a system called Elixir, I think that's what it's called. And they actually, They actually like standardize patients based on comorbidities, so I can probably select like patients who have hypertension, diabetes, any cholesterol. Like I can standardize them to one group, so I can, make them as a control versus like any other things like that. So hopefully I can control like the confounding variables with that post-op, and I think that's a big thing that we wanted to talk about too. So thank you. Yeah.
I presume this is done in younger people too sometimes. What sort of conditions would that
I'm sure with younger people, probably with trauma. It's probably not osteoarthritis, which is the reason we're focusing on this, but I'm sure with younger generations, probably just trauma, or I think that's probably trauma. That's off the top of my head, but I'll look into that more to see why younger patients receive a UKA. So thank you.
Any more comments or questions?
Just thinking to your answer to not that question, but the previous question, you said that you would put all of the individuals with comorbidities into a single group.
Yeah, sorry, I probably didn't explain that properly. So I think like if I select the data from the NIS, so you can like control for like variables like hypertension, diabetes, and that can help like avoid those conditions as like a confounding variable with the rest.
Wouldn't you kind of want to make sure that you've got individuals with those comorbidities in both groups?
Yes. Yeah, I will look into that. Thank you, Dr. Roach. Yeah.
Okay. Thank you.
Thank you.
Okay, judges ready? Please welcome our next presenter, Aviv Spillinger.
Hi everyone, I'm Aviv, and today I'll be discussing the presentations and outcomes of chronic rhinosinusitis following a liver and kidney transplant. So otolaryngologists are increasingly encountering populations of immunosuppressed patients, and one subpopulation of immunosuppressed patients are transplant recipients who, as you know, require lifelong immune-modulating drugs to minimize any chances of organ rejection. But at the same time, these medications place these patients at increased risk for developing opportunistic and potentially dangerous infections. Chronic rhinosinusitis, or CRS, is one of the most common disease entities in the United States that affects millions of Americans each year. But what may be a simple sinus infection in someone like you or me can be quite devastating and maybe fatal in someone with a weakened immune response. Near the sinus cavities reside some pretty important structures like the orbit and the brain. So you can see how spread of infection to these structures can be quite serious. Unfortunately, not much is known about how chronic rhinosinusitis, or CRS, manifests in transplant patients. And treatment guidelines for managing CRS in this vulnerable patient population, it's lacking. So therefore, the goals of this study really is to describe these patients, but also at the same time look for the factors that are associated with developing these serious complications, as well as helping these patients achieve disease resolution. So the study consisted of a retrospective chart review where we looked for patients who were diagnosed with CRS following liver kidney transplant at the Mayo Clinic over a 20-year period. And on each patient, the type of variables recorded included patient demographics and baseline characteristics, treatment types, and outcomes. And then we used a multivariate logistic regression modeling analysis to see which of these variables had any association with the development of complications, as well as achieving disease resolution. So a total of 57 patients were found to be diagnosed with CRS following a liver and kidney transplant at the Mayo Clinic. And almost every single patient was on some form of immunosuppressive medication. And most commonly, this consisted of triple therapy with prednisone, tacrolimus, and mycophenolate. A total of 33 patients required surgical intervention for their disease, and 30 patients, or just over half, achieved clinically confirmed disease resolution. And interestingly, despite being immunosuppressed, no patients showed any signs of intraorbital or intracranial involvement of their disease. And on a multivariate modeling analysis, the only factors that were associated with disease resolution were a higher presenting Lund-Mackay CT score. And a Lund-Mackay CT score is just a widely used radiographic method for staging CRS. And older age. So both a higher Lund-Mackay CT score and older age were significantly associated with decreased resolution in this study, while no other factors such as like white blood cell counts, absolute neutrophil counts, the type and duration of immunosuppressive medication, surgical intervention, none of that had any bearing or significant bearing on resolution in this study. So management of CRS in transplant patients is particularly challenged because of these patients' immunosuppressed states. And historically, there's significant apprehension that these patients may go on to develop quite aggressive disease manifestations, such as invasive fungal variants, and spread to crucial structures. So one of the more striking findings of this study was that no patients showed any signs of extrasinus involvement of their disease, despite being immunosuppressed. And other notable findings in the study include the decreased resolution seen in patients who are older and those with a higher Lund-Mackay CT score. And the association between older patient age and decreased CRS resolution may be particularly important, as expanding technologies and advancing eligibility criteria is only going to allow for an increasingly older transplant population. Certainly, this study is not without its limitations. Its retrospective nature really limits the recommendations we can make about standardized treatment protocols. And resolution in this study was defined using CT and endoscopic examinations, which doesn't take into account the potential for symptomatic improvement, which arguably is more important for patients. So in conclusion, intracranial and intraorbital spread of CRS in transplant patients may be lower than once thought. And otolaryngologists should have a patient-centered discussions about the expectations for resolution, especially in patients who come with a higher Lund-Mackay CT score and those who are older. I'd like to thank my fellow co-authors at the Mayo Clinic for their help with this work, and my mentor, Dr. Chobe. These are my references, and I'd like to thank you all for your attention. I really appreciate it.
Okay, comments, questions?
Hi, I just had a quick question for you. So you were showing that the biggest thing, the correlation that you can find is age, right? And I was just curious because we know that age can affect effector functions of immune cells, like actually change their profile.
Yeah.
And I don't know if there's any way to pull that, but is there data where you could actually separate them based on age, and then look at like their white blood cells, like their effector functions, or like do a comparison? I'm just curious.
You know, that we probably could do that. We haven't done that, but I think you like splitting, seeing if patients who are older had a different white blood cell count and absolute neutrophil count.
Or effector function. I don't even know if that data is there.
The white blood cell count, absolute neutrophil count can do, but it's in terms of different like immunotypes, that's been discussed a lot in the literature and is shown to actually maybe be involved in the pathogenesis of CRS, especially in older patients, but we didn't quite look at that. It's a really good question. I think the direction that this field is taking. Yeah.
You mentioned endoscopic sinus surgery. Could you tell us a bit more about that and how it works? And how it's done?
Of course. Luckily, I have these pictures right here. These are not the same patient. On your right, I have a pointer, right? Oh, there it is. No, this is a non-surgically treated patient. Here are the maxillary sinuses, the ethmoid sinuses. Anteriorly, you'll have the frontal and posterior, the sphenoid sinuses. And this is how it looks with no surgery. And right here, you can see, for instance, the opening to the maxillary sinus way bigger than this opening right here, which drains into the middle meatus. So really, the goal of surgery is to open up these cavities because, I mean, you can imagine trying to spray like steroids and antibiotics to penetrate these cavities could be quite hard, especially the maxillary sinus. And now you got a much greater area to apply these medications. And this is what chronic rhinosinusitis can look like. This is quite a severe case, not necessarily life-threatening in immunocompetent patients, but definitely quality of life issue. And this is quite severe with polyps and everything. So the goal for surgery really make it look like that, clear out all the junk, and now allow greater penetrance of medications.
Is it an easy operation to do?
Never done it. Hope one day, but I think surgeons have become quite comfortable with doing this, and it's routine care, and rhinologists do a handful of these per week. And I think with significant training, it's becoming their bread and butter. But I can't speak for them. Hopefully that's the case.
Were all the cases in your review treated with endoscopic surgery, or there were any case of open surgery?
Yeah, all the surgery done was only endoscopic.
Yep.
You may have said this earlier and I might have missed it, but where did you get your population from that you studied, and would that maybe explain some of the reasoning for the lack of complications you found?
Yeah, that's a good question. It was all performed at the Mayo Clinic, so all these patients were transplant recipients at the Mayo Clinic. And I hear they have good surgeons there, so maybe that could explain it. But there was another study done like a month ago, which also looked at similar population transplant recipients in Israel. There was about 30 of them, and none of them received complications either. So I think it's, while people used to be super worried that because of the weak immune response, we got to treat these patients ASAP with surgery, that might not be the prevalent thinking now in the field. Thanks for your question. Hey, John.
In your discussion, you mentioned that none of your patients had any extranasal complications. Have you noticed in the literature that patients with extranasal complications tended to have higher rates of complicated CRS?
Yeah, especially in like bone marrow recipients, they can have quite a number of complications, or definitely at an increased risk of spreading to the orbit and spreading to the brain. You guys all seen pictures on UWorld of Mucor and how that looks like. That's usually done in like, DKA people with a weakened immune response. So in terms of the immunosuppressed population as a whole, yeah, the development of extrasinus involvement and invasive fungal variants is a known complication. But what we're seeing here is, at least in the transplant population, they might not be quite as susceptible.
Last chance. Okay, thank you.
Thank you all.
Please welcome our final presenter, Ross Toriel.
Hi, my name is Ross, and I'm here to talk about emergency medical service-related violence in the out-of-hospital setting in Southeast Michigan. Now, previous studies have found that EMTs and paramedics have an injury rate more than 3 times higher than any other occupation in the U.S. And another study found that 75% of paramedics sampled in Canada experienced workplace violence within a previous 12-month period. And most recently, in 2018, a study found that EMS assaulted providers felt that that assault could have been prevented. Now, this specific study is looking at southeastern Michigan, including Wayne, Macomb, and Oakland counties. We looked at the prevalence, the type of violence, and the characteristics of the perpetrators and their victims. So we distributed an online survey to over 1,000 EMTs, paramedics, and medical first responders. We had a recruitment flyer that was read at various meetings, and we gave a $10 Amazon gift card as an incentive upon completion of the study. This was all carried out via the Detroit East Medical Control Authority, or DEMCA, and the study was structured to accept the first 150 survey responses just based on financial constraints of the gift card. We divided violence into 6 categories: verbal threat, intimidation, physical assault, sexual harassment, sexual assault, and stalking. So we ended up getting 137 responses, 19 female, 100 male. 65 EMTs, 66 paramedics, and 1 medical first responder. Now, 55% reported to be a victim of violence within the previous 6 months, while only about 36% reported receiving safety training within the last year. In order to keep the anonymity of our respondents, instead of asking their specific agencies, we asked them to report which medical control authority they primarily worked for and equated that to the county that they were in. So as you can see, 85% were in Demka, followed by 12% of Macomb County, and the rest were a much smaller percentage. When reporting the frequency of reported assaults, we divided the perpetrators into patients with a mental health history, patients suspected to be under the influence of alcohol or illicit drug use, family, coworkers, or hospital employees. Blue is for yes, that happened, red is for no. So this is for verbal threats, physical assault, intimidation, stalking, sexual harassment, and finally sexual assault. And keep in mind that it's kind of concerning that coworkers and hospital employees are also committing some of these acts of violence as well. We also documented the types of violence that happened as well, and it ranged from the most common to grabbing, punching, and spitting, all the way down to use of a firearm, slamming doors, and throwing fecal matter. We found that females had a 5-time greater odds of assault by a coworker. Paramedics had an increased odds of experiencing unintentional injuries than EMTs, and 911 respondents had a 3 times greater odds of experiencing violence in non-emergency basic life support transporters. When asked about safety training, those that had received training between a previous 6 to 12-month period had a decreased odds of experiencing sexual harassment, and those that believed that their leadership did an adequate job of protecting them from violence had a decreased odds of experiencing any violence within the previous 6 months. So of course there were some limitations. This was a convenient sample. The ability to reach the participants, we're not exactly sure if every EMT and paramedic received the email to actually take the survey. The fact that it was an online survey meant that we couldn't verify who was taking it. And we tried to mitigate the recall bias by only asking about the previous 6 months rather than, let's say, a year. And moving forward, we learned that just getting more buy-in from participating agencies and effectively communicating the importance of getting research and data to improve policies and procedures moving forward would get more buy-in and participation. So basically, over half of the responding EMS personnel in Southeast Michigan reported experiencing workplace violence within the previous 6 months. That's huge, and we should make a change. This study just shows that further research needs to be conducted with a larger sample population to find out what exactly is moving forward. Our emergency personnel need to be safe, healthy, and be able to respond to our time of need without fear of dangers and violence from the community that they serve. And further research might help alleviate and potentially develop better policies and procedures and trainings programs to prevent this. These are my references. I'd like to thank Damon Gorlick at Demka and Patrick Carabon, the biostatistician, and thank you very much.
Comments, questions?
On one of your slides, you said that paramedics are at a higher risk of violence than EMTs. Could you elaborate on that? Why do you think that is?
So I mean, it could be a number of reasons. So typically, when you're responding to a call, if it's an EMT and a paramedic, the paramedic might actually be the one that's receiving care while the EMT is driving the ambulance. So it could be the fact that the paramedics are just in more contact with the patient, because you can see from the graphs that the majority of the violence was carried out by patients. It could also be the fact that because 911 responders had a higher odds of violence, that the paramedics are more likely to respond to a 911 call than EMTs, which are going to respond to a non-911 transport, such as transporting someone to dialysis or between nursing facilities, which might be have less violence, as what we found.
So you mentioned that training is one of the factors that may decrease the risk of being exposed to violence. And what are the basis of this training?
So that's some of the information that I wasn't able to obtain. So I tried to contact the different agencies, and they haven't been willing to share the types of safety training that they put their employees through. I can only imagine that it's a training that they get in the first 6 months or so of when they start, and then I'm not really sure if they get an updated training every year. I can only hope that I can show them this data and we can do further research and they can apply it to their policies and procedures. But I would like to note that we did have an open answer section on the survey, and most of the respondents did say that they wanted continuous training at least once a year and that they weren't getting that. So.
Did you consider looking into a more like data-based way to collect these responses? Because it could be that some of these individuals that did receive like these assaults or anything might not still be working as an EMT or paramedic and therefore would not be included in your sample?
Absolutely. I think one of the challenges is trying to reach the different EMS personnel. This seemed like the most efficient way at this time, because one of the biggest challenges was getting participation and buy-in from the different agencies. And in order to do that, I had to go through DEMCA, which is a regulatory body, which isn't even the actual agency, but that was the best way to get them to participate. So to have them share information on extra EMTs is just very difficult. Some of the other information we did find was that there is about 10% of employees who, as a result of the violence, did miss days of work because of that, but it was about 10%.
My question is that do you know if most or if not all of these agencies are required to even provide safety training in the first place? And a follow-up question on that is, do you feel like the participants of the survey would find this training useful, or do they find it not useful?
So I'm not sure if they're actually required to. I think most agencies have some sort of initial training at the beginning. As for your other question, I'm not exactly sure. You're asking about if they find the specific training that they have currently useful. It seems like it is that they want more training, and a lot of people said that they wanted tactical training. Others discussed how they were afraid that they would lose their job if they were to protect themselves, so they just wanted more reassurance from their employer. So just continuous training on like how to protect yourself is kind of what everyone wanted.
Did you happen to collect any data on like where the environment of where the violence occurs? So like at the primary point where the paramedics are approaching the patients, or in transport, or at the hospital, or anything like that?
We did not ask that specific question. That is a good question to ask, but we were just worried about recall bias, like if they're really going to be able to remember those specific situations. We did ask about unintentional injuries though, and there were a significant amount, and usually if there's unintentional, it's in the actual transporting, but that's another question that we could ask on a further study.
Have you considered looking at how workplace violence for EMTs and paramedics compares to other healthcare workers?
Yeah, that's the plan for the next step. So my mentor previously to this study, and this is based off of, is a study that he completed on physicians in the emergency department and their rates of violence over I think it was a 2-year period. So what we can do is compare this data to that. The only problem is this sample size is so small, we would need to do another study on a bigger scale first to get some more reasonable data.
Right, last 2 questions.
At the beginning of your presentation, it seemed that you had the numbers of males and females that responded to your survey. And it seemed like the female population was significantly smaller than the male population. And I was wondering if this is representative of the entire population that you surveyed here, or is this maybe an anomaly, and does that cause you to question any of your findings?
Well, I can't say for sure because we only collected 137 responses. It would be wrong for me to say that that is a representative sample, but typically I think in this profession there are fewer females, and from my experience working as an EMT the last 7 years, that there are fewer females working. So I would say it's probably close, but we would need to do a larger sample size to really find out how that's going, because we sent out the survey. I believe there's about 2,000 EMTs that are actually employed and working, EMTs and paramedics, and there's thousands just in Wayne County and Oakland County, all the counties together, so there's just so many to survey.
Right, thank you.
Thank you.
We're not finished. Well, first of all, I'd like to thank all our presenters, and I thought all the presentations were great. Thank you. I'd like to thank our judges too, and the people who organised this. Now, there's a slight break now. We'll start again at 11:30 with Dr. Ora Hirsch-Peskovitz is going to give a presentation. Okay, welcome back. The final event of this morning is a keynote speaker, and it's my privilege to welcome Dr. Ora Hirsch-Peskovitz, who I'm sure you all know that she is the president of Oakland University and a physician. She has a very impressive resume, but the only thing I'm going to point out in that is that technically she is a faculty member of the Foundation of Medical Studies Department, so she belongs to us. She's one of us. And I wonder if that means that Dr. Gould, our chair, is her boss. I don't know. Anyway, this is a great privilege and pleasure to have her here, so please welcome Dr. Peskovitz.
Thank you. Okay. Well, I'm really delighted to be here with all of you, and first of all, congratulations to all of you for your participation in your Embark project. I have to say that I'm so proud of our OUWB students and of everything that you do, but one of the things that makes me especially proud is of our research program. And one of the reasons is that I'm particularly excited about research. It's a big part of my own personal background. And actually, research is actually what got me into medicine in the first place. So I don't know if any of you have heard my story of why I became a physician, but I'll maybe share it very briefly with you again. If you have heard it, I apologize. If you haven't, I'll just tell you again. So when I was in 9th grade, I was planning to become a pianist, and that's what I thought I was going to be for my career. But I was in a public school, and at that time I decided to take a course that was called Research and Development. And the reason I didn't really know what research and development was, but it wasn't because I was attracted to development or to research, but if you think back to your 9th grade, you might remember that, well, you might not remember, but I was particularly interested in boys. And as it happened, I was the only girl in that class. And so I think that's why I took it. So the class was all about developing an independent research project. And as it happened, I grew up in Bethesda, Maryland, which was in the backyard of the National Institutes of Health. And the idea was that you could develop, well, you were required to develop an independent research project that started at the beginning of the year and that went for an entire year. And we had mentors, and you could pick any mentor you wanted. We had some ideas from the class instructor, but you had guidance, and I picked a mentor who guided me at the NIH. It was the late 1960s. I know your parents weren't even born then, but my idea, because I was interested in music, was that if you played music to plants, I thought that they might grow better. So we were taught a little bit about the scientific design, and so I picked 3 groups of plants, a control group and 2 experimental groups. One experimental group I played classical music to, and so I had a control group, an experimental group that I played Beethoven to, and the 3rd experimental group, don't forget this was the late 1960s, so it was the time of the Beatles. So the 3rd group I played Roll Over Beethoven to. And so that was the basic experiment. And I wasn't very good at plant biology, so none of the plants grew. But I was just fascinated by the idea that you could design an experiment to test a hypothesis and then see whether or not it could work. Now, of course, it didn't work, but the concept that you could do this just absolutely fascinated me. And so I asked my mentor if such a thing was possible, if you could do this same sort of thing for humans, because I wasn't really interested in plants. Not just because the experiment didn't work, but it just wasn't my thing. So I said, do people ever do this sort of thing to test human questions? And he said, yes, you could become a physician scientist. And I spent the rest of my high school years after school every day going to the NIH, working on a variety of different things. It happened to be the era of X-ray crystallography, and I got to work on a project which was turned out to be X-ray crystallography of fibrinogen, and I was very excited about it. And so as a result, I ended up starting at Northwestern in a 6-year medical program. And it was all because of this interest in boys, but this project that I took in junior high school, at the time, middle school, 9th grade. So research really became a pivotal part of my lifelong interests. Now, when I want to talk about today, why is research so important to physicians? I think it's really fundamental, because if you think about what we would be like today in medicine without research, we would be in the Middle Ages. Think about all of the discoveries that we have today that are the result of important research. And you might think that so many discoveries maybe occurred a long time ago, secondary to research that took place a really long time ago. But I think about research discoveries that are happening every day, and why research and an understanding of research and research methodology is very important to all physicians, including those who may not pursue careers in research like I did. My career, today I don't actually perform research, but I did for the majority of my career. And I will tell you that every single physician needs to perform research. I was just telling a few of you who, the faculty that welcomed me as I was coming in, that my mother died last week, and it's a sad week for me. But my mother was not a physician, she was a nurse. But she practiced nursing in the era before and when penicillin was discovered. And I've been thinking about her life this week because, of course, she just died. But I remember very vividly when she told me about the discovery of penicillin and the impact that the discovery of penicillin had on patients that she had, and what kind of an impact a discovery like that had, not just penicillin, but all antibiotics. And if you think about what the research did to discover penicillin, that was mind-blowing and dramatic. And think about that research. But when I talked at my mother's funeral last Wednesday, I not only talked about how amazing that discovery was. My mother was really an amazing woman. She was ahead of her time because not only was there research that discovered antibiotics, but my mother recognized ahead of her time that antibiotics, if used excessively, would cause antibiotic resistance. And she recognized that, and so I remember as a child that she would not give us antibiotics when we had colds, when even pediatricians and I'm a pediatrician, were doing just that. And it took many years before research actually proved my mother to be right, that excessive use of antibiotics actually caused, and today is responsible for significant and rampant antibiotic abuse and disorders that we have in hospitals like here, MRSA, and other diseases that we have that are a result of antibiotic abuse. But that we would never have known that was it not for important research. So research is critical to so much of our understanding of what we do. I want to take you back to my own residency days. And I was an intern in 1980. And I was a pediatric intern in 1980. And the most devastating part of my experience then was, for me at least, how many of you were at my commencement talk? Were any of you there that heard me speak? Okay. And you may have heard me talk about the fact that I almost quit my residency because of a little girl who died with leukemia. Because in those days, in 1980, 95% of children who were diagnosed with cancer died from cancer. 95% of children died if they were diagnosed with cancer. Do you know what the likelihood of survival is today if a child is diagnosed with ALL? 90%. Over 90%. And that change from when I was a resident till today, that complete reversal from 90% death rate to 90% survival rate is 100% due to research. And it is dramatic, and that's just in the course of my lifetime. And it is such a dramatic thing to see. I'm not just a pediatrician, I'm a pediatric endocrinologist. Let me give you another example of something in my own specialty that has been dramatically changed in the course of my own practice and my career. Something that was just dramatically changed the life of children that I saw in the course of my career. What do you know about neonatal screening? Do you know what we screen for in this country, disorders that we screen for in newborns? Does anybody know? Students now. I'm not going to let faculty answer this question. Do you know what disorders we screen for when we do heel pricks on babies? Do you know what disorders? Raise your hand and I'll call on you. Do you know what conditions we screen for? PKU, that's one disorder. Any other diseases? Not every state screens for G6PD. And not every state screens for galactosemia. But one disorder that every state screens for. Yes? Not every state screens. One thing that every state, not every state screens for CF. One thing that every state in the country screens for. More common than those conditions you're talking about. No? Not diabetes? Oh, I heard somebody say it. Yes. Every state screens for hypothyroidism. Every state screens for hypothyroidism. Yes. And hypothyroidism, more than the other disorders you mentioned, is completely treatable. And without treatment, children with congenital hypothyroidism suffer severe disabilities. So that is another condition due to research that we have learned that is completely treatable. Another condition that's in my specialty of pediatric endocrinology, another condition that I don't think every state screens for yet, but many do, I think Michigan does, is congenital adrenal hyperplasia. These are conditions that, all due to research, we have completely changed individuals' lives. And were it not for research that has happened just within my training, not just my life, but just in the time since I graduated medical school, 30 to 40 years. That may sound like a long time to you, but it doesn't feel like a long time to me at all. So these are life-changing things for the individuals with these conditions, and they are dramatic changes. So the power of research is significant, and it's not just in a lab. They are clinically significant. And so I think it is terrific that all of you are getting exposed to the power of research. Whether or not you choose, as I did, to spend a very significant percent of my career doing research. So one of the things that I hope you will do for your entire career, even if you don't end up pursuing a laboratory-based career or even doing clinical research, is that you will always read journals. And so one of the things that I thought I would do with you today is share with you current issues of journals. So I just came back, I pulled 2 journals that are this week's journals, and I'll just show you very quickly how I read a journal. I will tell you that when I was a second-year medical student, I went to the library, something that we had libraries that were a little different than the way they are today, and I will tell you that the first time I looked at a medical journal when I was a second-year medical student, I will admit, when I looked at medical journals, I said, I'm never going to be able to read an article from a medical journal, because I was overwhelmed. And I vividly remember the experience of reading articles in medical journals and thinking that they were impossible to read, because I remember the experience of, first of all, the language being language that it didn't feel like English to me. And it wasn't, I'd already been in medical school for 2 years, but I did not feel that I could understand the words. But it wasn't just the words, it was also the format of the way the articles were written and what it was all about. But I do hope that one of the things that you will learn through your time here at OUWB is how to both read and appreciate the importance of reading medical journals. And I will tell you that today, and I'm a university president, I am on the faculty, but I don't spend most of my time dealing with the medical school. Today I read a minimum of 5 medical journals a week in my specialty, which is pediatrics and pediatric endocrinology, and general medical journals. And so the 2 examples that I gave today are not in my specialty, they're general medical journals. So I brought you 2 examples, one from JAMA and one from the New England Journal of Medicine. And I'll just show you how I read them, okay? And I thought this might be interesting to you. So I'll just show you what I do. And people read journals different ways, but I'll just give you an example of both of them. So let me just start with let's start with the New England Journal of Medicine. So that's this one, and you each have a copy. So, and because I have a lot of work to do, like running the whole university, and I want to read as much as possible, I don't read every article, and I don't read all of every article. This is what I typically do. I take a look at the table of contents, which is usually on the front of the journal. By the way, these are electronic now. You don't have to actually get the journal. I sometimes do still have the hard copy journals because I'm old, but you shouldn't waste paper. I did waste paper because I wanted to teach you how to do this. I did double-side it though, so. But I did this for teaching purposes. And then I will look at the table of contents and decide based on the table of contents which articles I'm interested in. And I may not be interested in all the articles. Sometimes when I do that, I discover that I've missed something that I really wished I had read. And sometimes somebody will bring it later to my attention and I think, oh my goodness, I read the whole issue and I missed that article that I was really particularly interested in. So if you look at this New England Journal of Medicine, you'll see that I didn't pick all of them. And actually, just to point out to you, I went back afterwards and I was quite interested later in this one that is page 2116 on the new segmented virus associated with human febrile illness in China. I went back later and reread that one because I thought afterwards that was pretty interesting. And so I went back and reread it. But I thought that the ones that I starred were pretty interesting. And so what I do is I look at all of these articles that I've starred, I read the titles, and I think these are interesting. Now, they may not be interesting to you, but these are the ones that are interesting to me. And based on that, I decide which ones I'm going to read. And in this case, I take a look at the abstracts of these. So let me tell, I picked one to share with you today. So the one that I picked was the article on page 2136, which is 5-year outcomes of gastric bypass in adolescents as compared with adults. And I thought this was one that we could discuss because it really wasn't that complicated, and I thought that we could discuss it together. And so turn to the back of that first page, and I'll just show you that almost every journal article in the New England Journal and in all journals have essentially the same format. They all have a background that tells you why is the article important. Well, in this case, it's important because bariatric surgery results in weight loss and health improvements in adults and in adolescents. But the question about this article is, we didn't know whether the outcomes differ according to age. And that was the purpose of this article. And to me, that's interesting because I'm a pediatrician. They wanted to know. And the New England Journal of Medicine is one of the most important journals. So in order to make it into the New England Journal of Medicine, it means this question hasn't really been previously addressed. And then they addressed the methods. How did they ask that question? Ask and answer it. And then they shared the results. And sometimes if I'm really in a hurry, I may or may not read the methods in details. I may not read the results in detail. I will go to the conclusions, look at the conclusions. If I'm interested in what they find, then I go back and read the methods and the results, and then I'll read the whole article. And here what they found is that adolescents and adults who underwent gastric bypass had marked weight loss that was similar in magnitude. So children, adolescents, and adults had a similar result from gastric bypass surgery 5 years after surgery. Adults had remission of diabetes and hypertension more often than adults. That's pretty interesting. And that was the result of the study. And if you want to know how they did it and more detail about the results, I read the article. And that's really important. Now, if you don't know enough about research, you wouldn't do this. But if you want to stay informed 10 years, 20 years after you're in private practice, and in my case, I still want to be informed about medicine, even though I don't actually see patients anymore, I read. And I do this all the time. And that's why I'm sharing this with you. And that's what you're learning by being in your Embark course. And if you can do this, I think you're going to be an amazing physician. Let me show you an example of another kind of article. But this shows you the scientific method. Now, many of the other articles are a little bit more complex, but this is from this week's New England Journal. And you're already trained to read and understand an article in the New England Journal of Medicine. And I think it's amazing that you can do this. So here is the front of this week's JAMA. And again, you can see the articles that I highlighted. I want to point out, though, that I always read one type of article, both in New England Journal of Medicine and in JAMA, because it's one of my favorites. And it's a section that's called A Piece of My Mind. And I just am highlighting it here. I never skip this section. And these are authors who share essentially personal stories. And in this case, it was called Metronome. I didn't copy the article for you. If you want to see it, go online and read it. But people tell their personal stories, and they're very interesting. And you do not even have to have a medical degree to read these stories. And when I spoke at the OUWB commencement, those of you that were there may remember that I told a story at the very end about the Sea of Galilee. I had published in this section an article that was called The Sea of Galilee. But the articles that are here are not research. They are stories that people tell. And they are typically written by people who have something personal to share. And they're lovely. And I encourage you to start reading those, because one day I would love to see articles written by OUWB faculty and students here in this section. They're really wonderful, and both here in JAMA and really in other medical journals. So I encourage you to write in this section. But the one that I shared with you today is actually a different article and a different kind of article. And this article addresses a huge dilemma, and one that I'm personally very interested in. Some of you may know that my partner, Dan, is a Beaumont doctor and a Beaumont cardiologist. And he and I have been arguing. I'm a widow, he's a widower, and he and I have been dating for over 6 years. He and I have been having this argument about eggs for the last, well, since our first date. I'm an endocrinologist, he's a cardiologist, and we've been arguing about the cholesterol in eggs since our very first date. So I very much enjoyed this article, except it didn't agree totally with me. But I enjoyed it because it just shows what I would call the pendulum swing in medicine. Another version of this is what I used to call the hem length phenomenon. And what I mean by the hem length phenomenon is, if you're a dress designer, there are only so many things you can do with a dress. You can make it shorter, you can make it longer, you can make it shorter, you can make it longer. There's so much you can do. There's really nothing new under the sun. And the same thing is true with fads in medicine. In my own specialty of endocrinology, we have too much estrogen, too little estrogen, too much estrogen, too little estrogen. And that is what has happened with my specialty. Well, here in cardiology, it's about eggs and cholesterol, dietary cholesterol. In other words, are eggs good for you or not good for you? Can you eat too many eggs or shouldn't you eat too many eggs? So this actually is about the cholesterol in eggs and dietary cholesterol. So this article, this particular piece refers to another article, and it's the editorial that refers to the article about eggs. And so I want to show you a different way to read. And I think it's very important that you not only read the primary data, but that you also read editorials about primary data. And so I encourage you, I wasn't going to read it with you, but I encourage you to read this, because you will see that controversies in medicine that are related to research continue. Because primary research, when I started in medicine, you were never supposed to eat eggs because of the dietary cholesterol in eggs. Then a few years ago, it became okay to eat eggs. And now you will see in this issue, again, it becomes controversial about whether or not you should eat eggs. And then this editorial raises the question again. So these are the various ways that what you are learning about research makes you not just able to do your Embark projects, but makes you an educated physician, so that you're not only learning your specific project, but you are becoming a very well-rounded physician, and you are learning skills that will enable you for the rest of your lives to be able to become informed, and so that when you treat your patients, you will have the most up-to-date information that will make you as informed as possible, because your patients will often also come to you. Sometimes they will have read information that they get off the internet. Sometimes they will read an article that's in the New York Times or some other public social media that will refer to an article, and sometimes they will read things that a friend has sent them that may come from, some garbage place, and you have to know how to help them to interpret what they read. And it's very important that you stay up to date and educated. So that's what I had to say. I'm happy to answer any questions, but I firmly believe in the importance of research and what you're learning here. So if you have any questions, I'll be happy to take them. please give me your name and tell me if, I think everybody's in the same year, right? Are you, okay, yeah.
Thank you very much for sharing this with us. So I'm curious to what your partner, the cardiologist, thinks about eggs.
You want to know which of us thinks what? Well, first of all, I made him eggs this morning, and he did eat them. But he's more cautious about, like the author of that article who says that he eats, I think, 1 egg every 2 days, and he eats 1 whole egg, and he mixes them with egg whites. My partner is more cautious about eggs than I am. I have a very low cholesterol and a high HDL, the total cholesterol. So I'm more comfortable eating eggs. I think an egg is a perfect food. So but he is more cautious. By the way, just to finish the thought on dietary foods, I'm also more liberal on dietary fat than he is.
So, I was just wondering, what is your opinion on, for example, the crossbreed between research articles and journals, or journalism, for example, like Stat News by the Boston Globe? It's not thoroughly a research article, but it's something that's a little bit quicker than publishing and research.
Yeah, I mean, I used to be more critical of things like that, but today I'm very much in favor, and I read things like that too, because I can get a lot of information in a short amount of time. So when you're reading and learning that way, I think it's fine. And I read a lot like that too. I do read journals, but I read them quickly because I don't have a lot of time. What I was saying is, when I want to learn more, when I see an article that interests me, then I go back and read the detail. But when I want to learn generally, I read the summaries, things like in Stat News, and then I only go to read the detail if I'm curious about more information. But to get a general sense of what's happening in the world, because there's so much information, that is not a bad way to learn at all. It's fine.
Hi, I'm Brandon. I just had a question of how do you approach it in a systematic manner, like, because we're just jumping in now at 2018 and there's already so much knowledge already out there. Should we go to textbooks first to get a kind of more baseline and then start in on the research, or how do you avoid getting overwhelmed?
Yeah, I mean, it's very easy to get overwhelmed, and I think that you can do both, but I don't see a problem with learning from research, what's happening now, but you do also have to have basic knowledge, but you're learning that in your courses, I'm sure. So I think you kind of do need to have both. I mean, that was one reason why I remember when I first started to pick up journals at your stage that I was overwhelmed. I mean, I do remember very vividly that feeling of trying to pick up a journal at your stage and just saying, I'll never be able to understand this. And then all of a sudden, I do know that when I first started to be able to read journals and it made sense to me was probably after I had done some clinical rotations. And by the way, even today there are journal articles I don't understand at all. If they're not in a specialty area that I understand, or they talk about drugs that I've never heard of, which happens. I mean, there are many medications I've never heard of. So then I don't understand them. But if it's in areas where I've had some experience, I do understand them. So that's going to happen to you. But when you start to do your clinical rotations, you will find that all of a sudden it clicks. And so don't be frightened by it or overwhelmed by it, and maybe my experience will help you. If you start to pick up these journals, and that's, by the way, one reason I suggest that you start to read these articles that are more approachable. It's one reason I picked 2 that I think you will understand. The one about obesity, you should be able to understand. And the commentary on cholesterol, you should be able to understand. And the articles that are a piece of my mind, which are stories, you should be able to understand. So you shouldn't be afraid of picking up journals. They should be your friends. There are stories in there. But there are some of these articles in these 2 journals that I just picked out for you, I can't understand them today, and I've been in medicine for 40 years. So I don't understand all the articles either.
That's very reassuring to hear. Last chance.
I understand them in my field. By the way, even in my field, I don't understand all of them either. You know, I'm not a bone, I'm an expert on puberty and growth. I'm not an expert on bone.
Hi, my name's Bree, and I'm just wondering if you have any time management advice for us as far as being someone who's very busy and has a lot of other priorities. How do you manage to still make staying up to date in the literature a priority and keeping it in your schedule?
Well, that is one reason I showed you what I do. I don't read every article. I do like staying up to date, and that's why I skim and I read the abstracts, and then I decide which ones I think I care to read. I do consider it a priority, though, and so and that's why I'm perfectly fine with reading those summary things like Stat News. Sometimes, though, I will, like I said, I pick up something, I occasionally come across something in the New York Times that was in the New England Journal or JAMA or another journal that I actually read, and I missed the article, and then I have to go back and get it. But I do read the abstracts because, and sometimes I will just read the conclusion. Sometimes I'll read the background, which tells me what is the problem they're trying to solve, and the conclusion. And then I say, that was interesting. How did they do it? And then I'll go read the method and the results. But sometimes I never read the method and the results. I just read the conclusion and I say, okay, I know what they found. That's good to know.
Last chance. Okay. Oh, we want one.
Yeah, go ahead.
Sorry, guys.
It's fine.
I was wondering if there was ever like a stagnant point in your career where you just felt like your research wasn't moving through, and what advice you have to get through that if you're just like trying to publish and it's not happening or anything like that.
Well, that happened to me many times, actually. You know, I have in the basement at Sunset Terrace today file drawers full of unfunded research projects. I mean, I was an NIH-funded investigator for 25 or 30 years maybe. And I have, for every grant I had funded, I probably have 8 or 10 that were not funded. And and I will tell you also, for every job I got, I had 5 that I didn't get. And for everything I wanted to do, I have multiple failures. So I had many times of either stagnation or, more importantly, failures. So I would just tell you, never think of a failure as a failure. It's a step to success. That's, if those of you who maybe heard me give another talk that I talk about shooting for the stars and landing on the moon. That's my motto. I never think of a failure. I do, at the time, you might find me sobbing in the corner, but then I just think of it as just a temporary grieving period. So that's my pattern, failure. But I see it as a step to success. It's a necessary step to the next, it's a step on the ladder to the next success. And you just have to look at it that way. And by the way, anybody who tells you otherwise is a liar. And I'm serious. Look at successful people. They don't have all successes. There's no one like that.
The answer to that last question is some of the best advice you'll get through that whole of the medical program, really. So thank you very much indeed. A few things to say before we go. I'd like to photograph with the finalists and Dr. Peskowitz before we go. I'd like to thank all the presenters. I thought all the presentations were great. Thank the judges. Thank my co-directors. I must remember to mention the Oakland University Credit Union, who are the corporate sponsors, so they'll be paying for the prizes. I'd like to thank Julie Strong, our coordinator, and in particular Dr. Roach. She's done a lot of the background organisation for all the presentations, so thank you in particular. Thank you. So, once you've completed your feedback to the presenters, Embark 5 is finished, so have a good day. Thank you.